The Canadian Breast Cancer Network's virtual patient education session. I'd like to welcome the chair of our board, Kathy Amandalea. Kathy, welcome. I'll turn it over to you.
Hi, welcome everyone. I'm so pleased to welcome you today to today's session hosted by the Canadian Breast Cancer Network for people diagnosed with early stage breast cancer. As someone who has personally experienced the breast cancer diagnosis, I understand how critically important access to information is when trying to make health-related decisions and post-treatment decisions. Along with the rest of the CBCN board, who have also experienced the breast cancer diagnosis firsthand, we would like to extend a warm welcome. Our hope is that the information shared in this session will help you and your family navigate each stage of this complex diagnosis. Today, we are pleased to welcome 4 expert speakers who will be sharing information about reducing the risk of recurrence, supports for managing the short and long-term side effects of cancer treatments, how to transform the emotional impact of this diagnosis into something positive, and where to find supports to advocate for yourself or a loved one. I would like to express our sincere gratitude to our sponsors who have made this event possible. Our gold level sponsor is Novartis. Our silver level sponsor is Pfizer Oncology. And our bronze level sponsors are AstraZeneca, Eli Lilly, Knights Therapeutics, Merck, and Roche. Thank you for your support. So before we begin, I would like to quickly review some housekeeping items. Each presenter will be answering questions right after their presentation. You can ask a question by typing it into the Q&A box. As all participant lines are muted, please feel free to submit questions throughout the presentation, but please note that they will be addressed at the end of each presentation. Please use the chat box if you are experiencing technical issues, and we will work to resolve them as quickly as possible. This webinar is being recorded, and a link for on-demand viewing will be sent out to all participants after this session. A link to a short evaluation will also be sent out after the session, and we would greatly appreciate if you could take a few minutes to fill this out, as it will help inform future sessions. I would now like to introduce our first presenter, Dr. Roochi Arora. Dr. Arora is a breast cancer and melanoma clinical and research fellow at the Juravinski Cancer Center in Hamilton, Ontario. She completed her medical school training at the University of Alberta, followed by her residence training in internal medicine and medical oncology at McMaster's University. Dr. Arora will be sharing insights into steps we can take to reduce the risk of recurrence. Thank you, Dr. Arora, for joining us today. I will turn the presentation over to you.
Thank you very much, Kathy, for that lovely introduction. So hello, everybody, and thank you to the Canadian Breast Cancer Network for allowing me to speak today, as well as to all of the attendees today. It's great to be here. So as Kathy mentioned, I'm Dr. Roochi Arora. I'm a medical oncologist at the Juravinski Cancer Center who's doing a bit of extra training in breast cancer and in melanoma, as well as finishing my master's. So today I'm going to talk to you about early stage breast cancer. What can you do to reduce the risk of breast cancer recurrence? So today we're going to talk specifically about early stage breast cancer risks of recurrence, the things you can do, including pharmacotherapy or medications, essentially, exercise and nutrition, and then we'll debunk some of the myths that are out there. So I think this is a good point to start with a case. This is a patient of mine. I just changed her name, but a pretty typical patient that I would see. So her name's Janet, a 45-year-old woman who had an early stage breast cancer in 2019. So she saw me. She had a 3-centimeter tumor. After surgery, it was, as I said, 3 centimeters. She had 5 out of 12 lymph nodes that were involved with some cancer. And the tumor was estrogen and progesterone receptor positive. positive and it was HER2 negative. So she underwent surgery, specifically a mastectomy and lymph node removal. And then following that, I did give her chemotherapy. She underwent radiation therapy, and she's now on tamoxifen, as well as a medicine called goserelin, also known as Zoladex, basically a ovarian suppression medication. And I'll talk a bit more about that in case you're not familiar with it. So Janet had a tough time with her recovery after surgery, after chemotherapy and radiation. She saw me a few months after all the treatment had been finished, and she'd gained 15 pounds. She wasn't as active anymore. And she sort of slipped back into some old habits, was drinking more alcohol. So when I saw her, we definitely reviewed the standard recommendations for a patient like herself who had early stage breast cancer. So the standard recommendations based on the Canadian guidelines would be for her to get annual mammograms, as well as physical examinations, and for her to have a minimum of 5 years of anti-hormonal therapy. So when Janet saw me, the burning question she had is, isn't my cancer gone now? So she was wondering, why does she need to take pills, and why does she need to even think about prevention if the cancer's already gone? So that was certainly a relevant point. And what I explained to her, and what I try to explain to a lot of patients, is that breast cancer is sneaky. So yes, surgery removes the cancer and the tumor and the lymph nodes. But the problem is that sometimes there are microscopic cells of cancer that are floating around in the bloodstream, and our eyes can't see them. Our blood tests cannot detect them, but they just float around, and sometimes they can go to sleep. They can sleep for a long time, and one day they can just decide that they wake up again and they start growing again. And that can happen in the lungs. It can happen in the brain. It can happen in the liver. It can happen in the bones. So there's some arrows there sort of pointing to spots of cancer in the bones. And it can happen in other organs as well. But the bottom line is that breast cancer is sneaky. It can come back in other organs of the body months or years later. And that's why this is so important to talk about how to prevent these scenarios from ever happening. Because if Janet or anybody were to end up in one of these situations, unfortunately, that's not a curable scenario. It's treatable, but it's not curable. So we want to prevent that as much as possible. So we'll start just by talking about pharmacotherapy, which basically just means drug treatments. Now, I want to emphasize that this is specifically for hormone receptor positive breast cancer. And so there are some differences if the breast cancer is not hormone receptor positive. So very importantly, we have anti-hormone therapy. There are different kinds that you may have heard of. So there's tamoxifen, as our patient Janet was on, and there's also the aromatase inhibitors. So examples of that would be letrozole or anastrozole, also known as Arimidex. And there is a slight benefit to getting the aromatase inhibitors over getting tamoxifen. So something called disease-free survival, which means living cancer-free for a bit longer. So we see that 2 or 3% of patients have a bit of an advantage if they get an aromatase inhibitor over tamoxifen, but that's only available for postmenopausal women. And I'll talk a little bit more about that. And then, as I mentioned, there's a medicine called Zoladex or goserelin, and that is a GnRH agonist, which is basically means it blocks the release of hormones from the pituitary, and effectively it shuts the ovaries down. So that basically helps with making, with sort of blocking estrogen in the body. So a bit about tamoxifen. It's an anti-estrogen drug. So specifically, it actually prevents estrogen from binding to its own receptor and exerting its effects on cancer cells. It's been around for quite a long time. It was approved in the 70s by the FDA. It was initially used for patients with metastatic hormone-positive breast cancer, but a little bit later in the 80s, it started to be used for early-stage breast cancer for prevention. There are quite a few clinical trials that have been done over the years that have shown that it does reduce recurrences of breast cancer. There's a few important breast cancer groups, the Early Breast Cancer Clinical Trialists Collaborative Group, as well as the NSABP that have done some of these very, very large studies. And so, of course, tamoxifen is not without some side effects. So many of you may be on tamoxifen right now and may recognize some of these side effects like hot flashes, mood changes, hair thinning, and sort of, weight gain is controversial, but I think a lot of my patients do tell me that difficulties with maintaining weight is common. On the other hand, there's the aromatase inhibitors. And so aromatase inhibitors work a little bit differently. So a lot of my patients who are postmenopausal, when I talk to them about, anti-hormone therapy for their estrogen positive breast cancer, they tell me, but I'm menopausal, like my ovaries don't work anymore. So, how could I have estrogen in the body if my ovaries are not working? And the reason is that even though the ovaries may not be working after menopause, fat cells still make estrogen. And so because of that, it's important to block that estrogen from being made. So aromatase inhibitors do exactly that. They block estrogen from being synthesized in fat cells. And so aromatase inhibitors were first studied in the early 2000s in the preventative setting. And there are quite a few studies that have shown that they do reduce the risk of cancer recurrence. And so people often ask me, how much do these medications, tamoxifen and aromatase inhibitors, how much do they reduce my risk? And it's always hard to give somebody a number. And certainly the exact, reduction in risk depends a lot on how high the risk is to begin with. So somebody who starts at a higher risk is going to get more benefit versus someone who starts at a lower risk. But I would say on the whole, usually whether it's tamoxifen or aromatase inhibitors, anti-hormone therapy usually cuts the risk almost by half. So whatever the risk was to start with, it's almost cut by half, maybe by about 40%. So ovarian suppression, this is something that I think not too many people know about, but I'll just touch on briefly. So ovarian suppression is basically in women who are premenopausal, so still having periods. Of course, that means that their ovaries are still working and ovaries are still making estrogen. And so what's been studied is the use of ovarian suppression. So basically giving medications, this is where I mentioned goserelin or Zoladex, giving an injection medication that actually shuts the ovaries down. And so there are a couple of clinical trials that have been done. One of them was called the Suppression of Ovarian Function trial. The other was called Tamoxifen and Exemestane trial. And basically what these trials looked at is trying to give, tamoxifen or exemestane with ovarian function suppression. And ultimately, what has been found is that for those women who are still having periods, for some of those women who are at higher risk of breast cancer coming back, there is benefit to adding ovarian suppression over just giving the tamoxifen or the exemestane alone. Now, again, this is not for everybody, but women who are at higher risk, so that may be a large tumor size, that may be positive lymph nodes, and there are sometimes other features too, they may benefit. And certainly what was found is that women under the age of 35, there is some benefit as well to using the ovarian function suppression in addition to tamoxifen or exemestane. So this is something that would be good to talk to your oncologist about if you think you fit into one of those groups. And I like this picture just because it explains really nicely how these medications work. So this is a lot, if any of my patients are on here, you will know that I always draw these pictures out for you in the clinic when I first meet them. So this is, a schematic of a breast cancer cell. Breast cancer cells have different receptors on their surface. So these would be estrogen receptors. So normally the ovaries make estrogen, and that estrogen binds to the estrogen receptor, and it's like food for the cancer cell, and the cancer cell can grow because of that. And so the way that tamoxifen works is that it actually binds to the estrogen receptor so that estrogen is not allowed to bind to that same receptor. And because of that, basically the cell has no food to grow and it ends up dying. On the other hand, Z stands for Zoladex, which is goserelin, the GnRH agonist. So it actually stops the ovaries from making estrogen. And in the same way, aromatase inhibitors stop the fat from making estrogen. So as you can see, if you have less estrogen around, and any estrogen that is around isn't even allowed to bind to the estrogen receptor on the cancer cells, you really, really do reduce the amount of available estrogen or available food for the cancer to grow. And that's sort of the underpinnings of how these medications work and how they are effective. So I'm not going to talk all about medical therapies today because I think those are very individualized discussions to have with your medical oncologist and your other oncologists. But I think it's important to understand that all of those things I talked about in terms of anti-hormonal therapy really only apply to patients who have estrogen positive or progesterone positive or both positive breast cancers. They don't apply to patients who are estrogen negative or progesterone negative. So chemotherapy, especially if a patient is hormone receptor negative, we often recommend that, not always, but if there are some higher risk features, we often recommend that. If a patient has a HER2 positive breast cancer, we often recommend chemotherapy with anti-HER2 therapy. And again, these all, whether or not you get this recommendation depends on a lot of features of the tumor, the size, the grade, the lymph node involvement, all sorts of things. And then sometimes also radiation may be recommended and possibly even further surgery. So these are all of the sort of standard medical therapies that will be, that may be part of your care. And you have, specialists involved in your care who are experts in all of these areas. And so that's really what they will talk to you about. But what I want to talk about is what else can you do beyond the standard recommendations that you get from your doctor. So the reason this is an important topic is because, so this is a graph from one of the major clinical trials that was done on in breast cancer. And basically what they looked at is giving patients with breast cancer, early stage breast cancer, anti-hormone treatment for 5 years. And so even though patients got the treatment for 5 years, they were actually followed for a total of 20 years just to see what happened in terms of breast cancer recurrence. So if you look at this graph up here, if you look at this yellow line, so that is basically patients who have what we call a T1 N0. So T1 basically just means a cancer that's less than 2 centimeters. And then N0 means none of the lymph nodes are involved. So 5 years, the patients were on the anti-hormonal therapy and then they stopped after 5 years, but they were followed all the way out to 20 years. And you can see, so at 10 years, 4% of patients, the cancer came back in a what we call distant site. So, somewhere other than the breast, like the liver or the lungs, the bones. At 15 years, it came back in 8% of patients. And even at 20 years, it came back in 13% of patients. And that's patients who had no lymph nodes involved. If they had some lymph nodes involved, you can see that the risks were even higher. And this other graph shows something similar, but basically just focuses on the lymph nodes, different amounts of lymph nodes being involved. So the bottom line of all of this is that even extending out to 20 years, there's always some degree of risk that the cancer can come back. And that's really important to understand because when we think about cancers like colon cancer or lung cancer, these are cancers that behave a bit more predictably, and we know that they're a bit more aggressive. So after 5 years, if those cancers like lung cancer or colon cancer, if they have not come back after 5 years, very likely they will not come back. But when it comes to hormone receptor positive breast cancer, yes, 5 years is the highest risk time for the cancer to come back, but it's important to understand that even beyond 5 years, there is still an elevated risk that the cancer can come back. And that's why it's so important to take preventative measures to try to make sure that it doesn't return in the future. So that's where, I was saying that breast cancer can be quite sneaky because it can go to sleep in the body for a long time and come back one day in the future. So we really do want to prevent that. And the other thing I'll mention is that I just want to emphasize this is for hormone positive breast cancer. So triple negative breast cancer or hormone negative HER2 positive breast cancer, that doesn't seem to have this same risk. They behave more like the other cancers I was mentioning, where, if it has not come back after the 5-year mark, really that cancer is unlikely to come back in the future. So knowing all of this, knowing that there is this, risk that extends out even to 20 years, Janet wants to know, what else can she do? So one possibility is something called extended adjuvant anti-hormonal therapy. So what that basically means is that continuing the anti-hormonal therapy for 10 years rather than 5 years. And that has been studied in a number of studies now. And it has been found that this can reduce the chances that the breast cancer recurs, and it can also reduce the mortality from breast cancer, or the chances of dying from the breast cancer. Now, this is not appropriate for everybody, and I'm sure that a lot of you who are on some of these medications may think, oh boy, I don't want to stay on that for 10 years. And so really it's only appropriate in patients who, again, are at higher risk, just like that graph I showed you where not everybody has the same risk. So if you're at higher risk, as in possibly a larger tumor size, or in particular, if there are positive lymph nodes, those are the patients where we really think about giving them 10 years over 5 years of anti-hormonal therapy. So another possible preventative medical treatment is something called bisphosphonates. So bisphosphonates are bone strengthening agents. They were first developed to actually make bones stronger, and they're used quite often by rheumatologists, who are bone doctors, to treat patients who have weak bones or osteoporosis to make those bones stronger. What's been found is that they can actually reduce the chances that the breast cancer comes back in the bones. Now, it's not a dramatic reduction in the risk. It's small, but there is some benefit. And I should mention this has only ever been studied in postmenopausal women, not in women who are still having periods. So this is just a picture here of a bone scan. And so all these black dots here are spots of cancer in the bone. And so this is, again, what we want to prevent. So breast cancer's favorite place to come back is the bones. It loves the bones much more than it loves any other part of the body. And so bisphosphonates can reduce the chances that the breast cancer comes back in the bones by about 1 to 2%. So what that means is that if you took 100 women who had early stage breast cancer that was hormone positive and they were postmenopausal, and you gave them these bisphosphonates, 1 or 2 of those women, you would be able to prevent a recurrence due to the bisphosphonates. Okay, so the benefit is small, but there is some possible benefit. And of course, like everything, there are some side effects, although I think most of my patients tell me they're quite minor. The day you receive the bisphosphonate, sometimes women can feel like they have a bit of a flu, so some aches and pains in the bones and just feeling a bit under the weather. It can cause low calcium levels. And then there's a few very rare things it can cause. So something called osteonecrosis of the jaw, where the jaw is not healing properly. And so for that reason, we tell our patients to avoid dental work around the time of the treatment. And then something called atypical femur fracture, which is basically a break in the leg in a very sort of atypical location. So we talked a lot about medications, but what else is there? So one of the biggest things when it comes to reducing the risk of breast cancer recurrence is to avoid weight gain. And many of you who have gone through breast cancer will agree that it's pretty common, unfortunately, to gain weight after breast cancer. And it's for a variety of reasons. It's a stressful process to go through, and many people stress eat during or after. There's quite a bit of fatigue after you've dealt with chemotherapy and radiation and surgery. And so that means moving a little bit less. And then there's some thought that maybe metabolism drops as well, just after everything that you have been through. However, it has definitely been shown that there is an increased risk of breast cancer recurrence and death related to gaining weight after breast cancer. And everybody uses sort of different numbers depending on the study you look at. Different kind of percentages of weight gain have been shown to be detrimental. Some will say avoid 10% or more weight gain. I think as much as possible, just avoiding weight gain in general is the best recommendation. The other thing is actually possibly weight loss. So weight loss has been associated with lower inflammatory blood markers. Now, that doesn't necessarily translate into lower risk of breast cancer recurrence, but there is some thought that higher inflammation in the bloodstream can lead to recurrence of breast cancer. And there's some early studies and signals that weight loss is actually effective in reducing the risk of breast cancer recurrence. And there are some ongoing studies about this right now. Exercise was studied quite a bit, actually. Probably the most notable study was done in 2017 in the Canadian Medical Association Journal, where they did a large review and basically found that 150 minutes of exercise per week, moderate to vigorous activity, can reduce the mortality, overall mortality, by 40%. And so that's very, very dramatic. That's actually the same amount of benefit that you would get from taking anti-hormonal pill treatments for 5 years. And on top of that, there's a lot of other benefits to exercise too. It makes you more fit, it makes you stronger, it improves quality of life. It can help with anxiety and depression, which are very, very common after dealing with breast cancer. It can help combat fatigue, and it can just make you feel better about your body composition and body image overall. Now, what about things that we should avoid or limit as much as possible? So we do want to avoid, if the breast cancer was hormone positive, avoid what we call exogenous or external sources of estrogen and progesterone. So that includes things like hormone-containing herbal supplements, as well as hormonal contraception. So sometimes it's obvious that something contains estrogen or progesterone. That's like hormone contraception, the patch or the pills, but sometimes it's less obvious. And so these are some supplements that can be found over the counter, but they actually do contain estrogen or estrogen derivatives in them. And so these are things that would be important to avoid if you had a hormone receptor positive breast cancer. There's some thought that saturated fats would be important to avoid. This is not entirely proven right now, and we're not even sure if it's necessarily the fat itself or if it's just because of the association with weight gain potentially. But there is some thought that avoiding saturated fats would be important in terms of reducing breast cancer recurrence. And I think just in general for maintaining good cardiovascular health, avoiding or limiting saturated fats. Alcohol. So alcohol has certainly been studied. So there was a large study called the Life After Cancer Epidemiology Study, where they looked at a few different kinds of cancer, but notably breast cancer. And they found that women who had 3 to 4 drinks per week had a higher risk of breast cancer coming back compared to those who drank 0 or 1 drinks per week. So I'm not saying that you need to completely cut out alcohol, but certainly limiting alcohol as much as possible does seem to have benefit in terms of reducing breast cancer recurrence. And it seems that the women who are, most susceptible to breast cancer or to the, risk of recurrence related to alcohol are those who are overweight and those who are postmenopausal. Quitting smoking. So smoking, I think everybody across the board understands is not good for you. There is some evidence that quitting smoking can help reduce the chances of breast cancer coming back and also other kinds of cancers in general, reducing the chances that you may develop one of those. So in general, quitting smoking is good for a variety of reasons. And then there are some things that are a bit more inconclusive. So we just don't necessarily have enough information to make a confident recommendation for or against any of these factors on this list. So a lot of this has to do with diet. And so I get questions a lot from patients about, soy, tofu, foods with phytoestrogens. Honestly, the studies are, we don't have enough studies, I think, to guide us right now. If you're really worried, I think it's very reasonable to avoid or limit your intake of these things, but there's really no sort of conclusive hard evidence right now to guide us. Fat, I sort of touched on when we talked about saturated fats. Fruits and vegetables, as well as antioxidants. I mean, in theory, it sounds great that yes, taking them would reduce the risk of breast cancer recurrence. But again, we just don't have enough evidence to say that that's proven. and then anti-inflammatory drugs and aspirin. So I talked about how inflammation does seem to be related to either new cancers forming or breast cancer reoccurring. But does that mean that taking an anti-inflammatory or taking aspirin, which is an anti-inflammatory, does that mean it'll lower the chances of cancer coming back? And we're not entirely convinced of that quite yet. And so these are not really standard recommendations just because we don't have enough evidence to back that up. And then there are other things you can do that, they have benefits, not necessarily breast cancer benefits, but just benefits in general, including improved quality of life and stress reduction, which I think a lot of people who have dealt with breast cancer would benefit from. So some of the complementary therapies, and maybe Dr. Seely will touch on some of these, but these include acupuncture, yoga, and mindfulness therapy. And then there are a few things that there's no benefit, but there's also no harm. So these are, some of the things that maybe there were some myths out there in the past that they were associated with breast cancer, but there's really no benefit or no harm associated with these. So fortunate for me, caffeine, because I need my coffee. So there's no association there. Gynecologic procedures like abortions or tubal ligations, cosmetic breast implants. Many people, even after breast cancer, do get breast implants as part of reconstruction. So no benefit or no harm. Hair dyes and electric blankets. So I will just summarize here. So preventing breast cancer recurrence is important. And hopefully I have convinced you of that today, that we really want to make sure that women and men who get breast cancer are not ending up in the scenario where their breast cancer has spread. We have talked today about some proven ways to reduce breast cancer recurrence. The biggest thing I hope to stress is that I want you to follow your oncologist's recommendations in terms of chemotherapy, anti-hormone therapy, radiation, and surgery, possibly extending anti-hormonal therapy up to 10 years in certain scenarios, avoiding weight gain, limiting alcohol intake, and avoiding smoking. And this is just a little picture from the American Cancer Society, which pretty much shows exactly what we talked about. So trying to maintain a healthy weight, not smoking, staying active, and as much as possible, avoiding or limiting alcohol intake. And just some helpful resources for you if you want to learn more about breast cancer. So of course, the Canadian Breast Cancer Network is a fantastic resource, but other places would be cancer.org, although just be careful because that's an American website. So some things may be a little bit different on there. And then of course, Cancer Care Ontario has lots of great information for patients as well. And that's it. So I can take any questions now.
Wonderful. Thanks so much, Dr. Arora, for your presentation. That was a great overview and a lot covered in a very short amount of time. So we do have about 10 minutes left for questions. And I'd invite anyone who would like to ask a question to use the Q&A tab. We have a lot of questions to start with already, so we'll try to get to as many as possible. So the first question, back to the HR positive breast cancer, does your level of estrogen increase your risk for recurrence? So for example, this patient's estrogen level was 90%. What does that mean for her likelihood of recurring?
So it's a good question. So the percentage of estrogen on the hormone receptors, so when the pathologist basically looks at the breast cancer under the microscope, they tell you the percentage of estrogen. That's not the percentage of estrogen in the blood. That's actually the percentage of breast cancer cells that are expressing estrogen on them. So what that actually tells you is how sensitive the cancer is to estrogen and therefore to anti-hormone therapy. So it doesn't necessarily correlate with chances or risks of recurrence, but it correlates well with how responsive the cancer would be to anti-hormone therapy.
Perfect. Thank you. That I think helps clarify that quite a bit. And looking at a type of testing, so in terms of oncogenomics, looking at the oncotype score, and someone's asking if the oncotype score, so oncotype DX, for example, score is high, is that considered a high risk for recurrence? Or does that mostly just help inform treatment options?
Yes, great question. So both. So a higher oncotype score is associated with a higher risk of breast cancer recurrence. And a higher oncotype score does tell us that somebody is going to benefit more from chemotherapy. And we have different cutoffs depending on if somebody's premenopausal or postmenopausal. But generally speaking, yes, the higher the score, the higher risk of recurrence and the more benefit from chemotherapy.
Perfect. Thanks for clarifying that as well. And then one around taking aromatase inhibitors. So are there any studies that showing any benefits to taking aromatase inhibitors more than 10 years?
Oh, good question. So I don't think we've done any formal studies in terms of 10 years. There is a study that was basically looking at extending aromatase inhibitors to 10 years. And then in the other arm of the study, a lot of the patients had actually already been on 5 years of tamoxifen. So in essence, they were actually on therapy for about 15 years. So there is possibly some benefit to longer therapy. I think we're not, like, I think the jury's out right now just because we don't have enough data to support that. But the thing I always tell my patients is in 5 years or in 10 years, we'll definitely know more. So when it comes time to make that decision, I think we'll have more information. But I think it makes a lot of theoretical sense because those graphs I showed where, even at 20 years, there is, some existing risk of recurrence. It does seem very reasonable from a theoretical standpoint that keeping the estrogen levels low for as long as possible would reduce the risk of recurrence. But I don't think any oncologists are recommending right now extending therapy beyond 10 years, just because we don't have enough data. And probably a lot of you will know that these drugs are not entirely without problems. Like there are some side effects to them as well. And it's important for maintaining bone health and whatnot.
So that's something to sort of keep following up on in terms of looking at the research and studies. Okay. So we have time for a couple more questions here. Another one around actually triple negative breast cancer. And you did touch on this, but really specifically looking at whether or not compared to other types of cancers who have some of these longer treatments to help continue to suppress hormones and whatnot, is there a higher risk of recurrence for triple negative breast cancers? And then also, if you could clarify, if cancer does return in the bone, for example, is it considered bone cancer or is it still considered breast cancer? And maybe clarifying that for this question.
For sure, yeah. So the first question was the risks of recurrence for triple negative. So triple negative. So I always kind of joke with my patients and I say that triple negative is like this grab bag basket. It's like everything else. So, you've got your hormone positive, you've got your HER2 positive, and then you've got your triple negative, which is everything else. And it's not really fair to lump everybody together because if you were to talk about the United States and you were to say, okay, there's New York and there's LA and then there's everything else is not necessarily the same, right? Like Arizona is very different from Maine, which is very different from, North Carolina, for example. So it's really not fair to put everybody who's triple negative into the same basket. In general, we do get a bit more nervous with triple negative breast cancers in terms of the recurrence. That's why a lot of those patients, the recommendation is to get chemotherapy because there really is no other medical option for those patients. I do tend to follow those patients a little bit closer as well. But the sort of positive part of triple negative breast cancer is that, as I mentioned, beyond the 5 years, if it hasn't come back, is very unlikely to come back. Oh, and then the other question about the bone cancer. So one of my mentors at the Juravinski, Dr. Tozer, so he always makes this joke, but it's a great way to explain this. So when he goes to Mexico, he has not suddenly become Mexican. He's a Canadian who's in Mexico. So in the same respect, if you have breast cancer and it goes to the bones, it is not transformed into bone cancer. It is breast cancer that has traveled to the bones. And the same goes with if it has traveled to the liver or has traveled to the brain. So it's all still breast cancer. It's just migrated to different places.
I think that's that's a great way to clarify that. And someone asking about how do you know your onco score? So a little bit more about back to that Oncotype DX and what that means.
So Oncotype DX, we would have to order that test. So your oncologist can order the test. It's only appropriate for certain people. So basically the purpose of the test is to help us decide if a patient who has early stage breast cancer that is hormone positive, HER2 negative, at least 1 centimeter and is lymph node negative. So it helps us decide for those patients, should we offer them chemotherapy or not? So those are the patients where we are approved to actually order that test, get the province to pay for it, and basically what they do is they send the tumor to California and they do testing on it, and they look at 21 different genes, and based on the results of their kind of fancy testing that they do, they give us a number, and then that number is essentially going to correlate with the risk of breast cancer recurrence. So that's how you would know what your score is. So I think it's really important. I know a lot of people get very curious about it, and they just say, you know, well, I just want to know. But it's really important to understand that it's only an appropriate test for certain people. If you do it out of context, if you do it for somebody who has, for example, positive lymph nodes, or if somebody with a triple negative breast cancer wants it, it's not really been studied in those populations. And because of that, you can't necessarily trust the results. We don't know what those results mean.
Okay, thanks for that clarification, and something that patients can definitely speak to their oncologist about then in terms of whether or not it would be appropriate for them. Mm-hmm. We do have a couple questions also regarding radiation, and we do have Dr. Rob Rutledge, who is presenting later on a different topic, but who is also a radiation oncologist. So maybe we'll actually direct a couple questions to Dr. Rutledge in terms of radiation. Hi, Dr. Rutledge. We can see you there now and hear you. So in terms of radiation, is it possible for the cancer to come back in the same area that's been radiated? And if so, would it be in months or years, or is there any way to predict that?
Yeah, so like chemotherapy, we offer radiation treatments because there's a possibility there might be some cancer cells left over in that area. So for instance, within the breast. And typically, if you give radiation to the breast after a surgery, you have a 90 or 95% chance the cancer will not come back, but therefore it means that there's a 5 to 10% chance the cancer could come back. And in that situation, typically what would happen if it's just a conservative breast surgery to start out with, they would remove the entire breast or do a mastectomy at that point.
Okay, thank you for that answer. And one more radiation question around a patient having radiation on one of her breasts, her left breast actually, and concerns about damages to the lung and heart. And how would you actually know if this has happened? What measures are in place to detect that type of damage? Right,
so radiation goes into the breast tissue, and some of it does actually exit into the lung, and it means that there's a little bit of scarring on the lung tissue, just in the front part of the lung, and depending on whether you get the lymph nodes involved, in the top part of the lung as well. So we actually expect that to happen, but because it's such a small amount of lung, almost everybody has no problems with their breathing after radiotherapy. If a person did a CAT scan on that area, 5 years later, 10 years later, 20 years later, you'd actually see some scarring. So typically, it doesn't affect how you function on the day-to-day. So typically we don't kind of look for it. If there's some type of problem in the future, then we start to investigate further. But we're expecting that there will be a little bit of scarring there. And the other thing is that the radiation that's delivered across the country, such high precision that the chance of damage to the heart is actually quite low, because we kind of wrap the radiation around in the left side if it's a left breast cancer, and it's not really an issue on the right side.
Okay, great. Thanks for clarifying that. And I think then, Dr. Arora, we have time for one more question for you, and then we'll have to move on. I appreciate that there's a lot of questions in here, and this one actually sort of speaks to specifically what's being the impact of the pandemic and halting medication or having things transition a little bit during the pandemic. And this patient's asking specifically, are there worries about putting off or temporarily halting Zometa for early stage cancer due to the pandemic? But I think just in the broader space, in terms of obviously patients are being impacted, whether it's, there's Zometa treatments or other treatments, can you speak a little bit to how concerned patients should be as these treatment schedules are changed or things are postponed or whatnot?
Yeah, for sure. So I think we have all, as medical oncologists, we've all really tried to make it a priority for at least our high-risk patients, but really for everybody, to still be able to give them the best treatment possible for their breast cancer. So things that are, potentially of less benefit, like Zometa, for example. I mean, I talked about Zometa, right? The benefit is certainly quite small. I think it's sort of sensible that it's moved down the priority list, just because we really do want to prioritize if somebody needs chemotherapy to be able to provide that to them. Yeah, I think honestly, in my experience, at least I can speak about the Juravinski Cancer Center, we have all really made it a priority to keep our patients on track and still be able to give them the best treatments possible. I have had a few instances myself where if patients were running into a lot of side effects and I was worried they might be admitted to hospital, just with the pandemic and everything going on, we sort of collectively decided with some shared decision making that it was probably not in their best interest to continue chemotherapy. But I think also now that we just know more about the coronavirus, we know more about the pandemic, we're a little bit better equipped now to handle what comes our way. And also Cancer Care Ontario has given us some very clear guidance in terms of how to prioritize our treatments. And so I think all that to basically say that patients should not be overly concerned. Cancer care gets a lot of, I guess, priority and a lot of attention for good reason. That's one of the main reasons I wanted to become an oncologist, is because it is a very high stakes, high priority, illness to treat. And so I think those patients who do really need to continue their treatments, they will get it.
I think that's a great note to end on and very reassuring. And you're getting the thumbs up from Dr. Rutledge as well. So thank you so much for sharing your knowledge with us and for your time. We really appreciate you being with us today.
You're welcome.
We will turn it back to Kathy for our next presenter. Thank you, Dr. Arora.
Thank you, Dr. Arora. Thank you for that wonderful and engaging, insightful presentation. I would now like to welcome Dr. Dougal Seely, our next presenter. Dr. Seely is a naturopathic doctor and CEO of the Center of Health Innovation. He is also the founder and a practitioner at the Ottawa Integrative Cancer Center. Dr. Seely will be sharing insights about managing the side effects of cancer treatment through the use of integrative medication and medicine. Dr. Seely, I will now turn the presentation over to you. Thank you.
Great, thank you so much. Are you able to hear me clearly?
Yes, we can. Thank you.
Okay, great. Well, that was a pleasure to hear Dr. Arora speak, and I think this is follows well from some of that. And yeah, I'm delighted to be able to talk to you today and to share some of my perspective relating to integrative medicine as it intersects with breast cancer. So just briefly, I'm going to talk a little bit about integrative oncology as a whole, and hopefully support people to become better decision makers and consumers of complementary medicine, especially in navigating through the website and in communication with others, either healthcare practitioners or CAM practitioners in the field. I'm going to speak a little bit about some of the guidelines for integrating complementary medicine into breast cancer care, and then some key lifestyle touch points, some of which have already been touched on as well. But I want to emphasize some of those points again. And then as well, a little bit about phytoestrogens and safety concerns relating to that and to interactions as well. And hopefully with some a few minutes left for some questions at the end. So I really think it's important to understand and to define the terms well when you're looking at complementary and integrative medicine, because many people see this as a mix of alternative and complementary medicine, and there really is some distinction there. Alternative medicine is more the use of non-mainstream healthcare instead of conventional treatment. So it's really a choice, not necessarily in opposition, but it's choosing non-conventional care in an alternative sense. Whereas complementary and integrative medicine is rather using it either these therapies alongside in the form of complementary medicine, or ideally integrated with mainstream healthcare that one is going to find with one's family physician and GP, and also at the hospital. So I'm very much an advocate for integrative medicine. Certainly many patients are looking at alternative medicine closely, but I think it's just important to have that distinction in the mix in terms of what you're looking at and how you're approaching this. We know that complementary and alternative medicine, which is the field of inquiry around around this, this whole field is the way it's defined. So it does lump together everything in complementary and alternative medicine, which is a bit of a disservice in some ways and also muddies the field, but that's the way it's defined. So CAM is sort of the umbrella term, and there has certainly been a large increase in CAM use and a large use of CAM use and complementary medicine use across Canada and North America and globally, and that seems to be increasing, if anything. We know in cancer that there is a huge proportion of patients that are actually using this form of medicine, and in breast cancer, that actually goes up to even almost 90% of people who've had breast cancer or are dealing with it are using some form of complementary medicine. And so the common therapies that are included within this sort of umbrella include nutritional counseling, supplementations, the use of herbal medicine, even physical activity is being sort of lumped into CAM medicine at times, use of acupuncture and traditional Chinese medicine, and then some of the mind-body therapies, things like meditation yoga, Qigong, and Tai Chi. And then there's psychotherapy and visualization, lifestyle counseling, and physical therapies, including chiropractic and massage. So you can see how there's just such a wide range of these types of therapies. And I think it's very, it's important to be specific about what one's looking at and also what type of benefit that you're trying to achieve. And I think part of the problem that happens in our in popular media and also in consultations with practitioners is that this whole thing gets kind of lumped together. We're seeing better distinction, better understanding of this, so it's encouraging. I think it's really key though in this is to understand where you're getting the information, and it can be incredibly overwhelming. There can be information that one is provided at a healthcare practitioner, at a health food store, for example. You can get this on all kinds of different resources that are on the net, including some that I would say are rather sensationalist and stark in their presentation. You can get it on popular media shows. You can get it obviously from Dr. Google and finding all kinds of information. And so really looking at what is good information, what is misinformation, what perhaps is anxiety provoking and overload for this is something to be really aware of as you enter into this field, because there is so much hype out there and there really is a lot of misinformation. Some of the consequences of this misinformation is that there can be a choice to refuse conventional treatment based on hearing that there's a harm to it. There may be a belief in natural cures that are coming forward and that are promoted within the internet. And you can, if you follow that path, you'll be exposed to more and more of that, because we know that algorithms are certainly designed to present what the consumer is looking for, and that can reinforce itself. So really important, and more important even in this time now. There's a lot of costs that you can incur, both financially and in terms of time, on ineffective or untested therapies as well. And that there's the potential for taking therapies that may interact as well with conventional treatments and that may in fact be unsafe. And just to reinforce that information overload and the stress and anxiety that can be triggered as a result. So some of the red flags I would say are useful to consider in this is a reliance on testimonials from, one or two people that have had an incredibly powerful experience and are relaying this. That sort of becomes the thing that one is very aware of. And it's sort of the idea that, we probably have a sense that shark attacks are more frequent than drownings, perhaps, because they, take a major predominance in the news, whereas drownings are far more frequent. So my point there is anecdote, well placed, can be very powerful, but may be misinformation. Sensationalist claims in the same way, reliance on preclinical data from studies in animals or in vitro studies that are then emphasized and augmented in a way to suggest there's an effect when we don't necessarily know in clinic is important. Looking at conflicts of interest, looking at conspiracy theories, sort of lumping all cancers together as one disease, cherry picking research studies, statements without references, one-sided storytelling, and scare tactics, and actually blaming the patient in some cases. These are some of the things that are important to look out for when you're distilling and looking at the information. I would say that good resources are authored typically by someone who's adequately trained and educated, or may come from a larger, more sort of well-known institution that has a credibility that they need to maintain. So they're gonna really, provide information that is well reviewed. Ideally, there should be references, and there should be some balance for the information too, not just necessarily throwing things out, nor completely supporting them, but providing both sides of the story. So some sources of good information. There's the American Institute for Cancer Research, the Memorial Sloan. They've got some information around herbs. There's our site where we've produced some monographs for both patients and for professionals. There's the World Cancer Research Fund. There's the larger organizations in Ontario and in Canada. And of course, there's the Canadian Breast Cancer Network. And then there's another one that I would say is quite good. It's Beyond Conventional Cancer Therapies, this one here, which gives a very good detailed overview of many of the different therapies that people are considering. And I think that we're going to see that grow over time. But I would say that it's really helpful to take some guidance with a practitioner that knows the area and that can be an information guide in some ways and help you distill some of that information. And it takes off some of the burden for you or family members to do this incredible review that you could do on the internet, but really can be very confusing and can cause some conflict. So this is a little a moment of break to look at this in terms of that, the effect that we can get. So Googling it can create anxiety. The integrative oncology is really a field of inquiry that has developed over the last 20 years and recently has taken a very sort of formalized definition. But this is the inclusion of evidence-informed complementary medicine that's integrated with conventional care. And the emphasis certainly on whole person, holistic approach to care, where it's not purely focused on the pathophysiology of the disease, but looks at the entirety of the person. And I think anyone who's a good physician will look at this with you. So it's not, unique to integrative care, but integrative medicine really does emphasize that holistic component. And it looks at the person in terms of their environment as well. So why integrative oncology? Well, people want to, I think in terms of people that are in the field that are trying to promote this as a field of research and clinical care, is one thing is to support better informed patient decision-making around this area, but also to obviously decrease the actual side effects of treatments, improve quality of life, reduce some of the risk factors that are associated with recurrence that maybe can be accessed outside of conventional healthcare. And then also to slow disease progression and enhance the effect potentially of some of the conventional treatments like chemotherapy or radiation. And then I think a really important aspect of this is to provide some sense of empowerment and control to the patient to help them to make choices that they have much more control over. And really looking at what is the most important for the patient. So this is a review that we did that was actually a practice guidelines that we created over a couple of years, and that was published in the journal supported by the American Cancer Society. And this is a very sort of extensive review of different natural therapies that are used for symptom management and supportive care, really, in terms of treatment for breast cancer. It's not about survival, it's about quality of life and symptom management, which is the focus of this. So I'm going to go through this relatively quickly, but just this part of it, just to give you a sense of some of the findings. And this is publicly available, certainly, if you want to dig into it. But the interventions of interest from this review included natural therapies like botanical medicines, herbal medicines, vitamins, minerals, supplements, etc. It looked also at mind-body practices, and I think we're going to hear a lot more about that from Dr. Rutledge as well. But looking at meditation, yoga, hypnosis, imagery, creative therapies, stress management, Tai Chi are things that we looked at in this. And basically, we did an extensive review of all of the medical literature to try to pull through good studies that provided evidence on that. We looked at acupuncture and massage therapy, and then whole systems of care, including naturopathic medicine and traditional Chinese medicine. We did not include a review of diet or physical activity or energy balance in terms of nutrition, because these have been reviewed elsewhere. So the relevant outcomes that we focused on and that came through from this search and synthesis, were things like fatigue, symptoms associated with GI upset, including nausea, vomiting, and diarrhea, constipation, gynecological related ones, hematological or blood related ones, issues related to lymphedema and swelling in the arms post-surgery, neurological, neuromuscular, psychological quality of life, vasomotor symptoms as well, which would reflect on hot flashes and response to hormonal therapy in particular, and then a few others, including sleep and pain. So we looked at 9 different databases, and we looked at randomized controlled trials, which are considered the best study design when looking at single interventions. Not necessarily always applicable well to integrative medicine, but nevertheless good for this particular focus. And we were looking at studies that at least had 50% of people in the group that were breast cancer patients. And that was, the review was completed in 2015. The publication actually came out in 2017 and has been updated since. And these were limited to English language publications, so that is certainly a limitation. So I won't go through all of this, but really the key point here, I would say, is that we graded each of the different studies according to their reliability and the collectivity of the different studies together. And then the grade was basically the recommendation whether or not this modality or practice should be offered or could be considered. So A and B, strong recommendations, a lot of evidence to base that on, obviously A being stronger than B. C would be, it could be potentially recommended. There's enough evidence to recommend it, but certainly not as strong as A and B. And then D would be a recommendation against the service. You'll see very, very few things came up from that. And then I, which is really the key things for I, is that there's not enough evidence. And that's the vast majority of many of the complementary medicine therapies, because there's just not tons of evidence. There is evidence for sure, and it's growing. So I would take I don't agree with the statement that there's no evidence, but there is certainly less than what we would like to be able to make these kind of strong recommendations. So in terms of anxiety and stress reduction, we see that meditation actually has an incredibly strong recommendation. Lots of studies came forward that supports the use of meditation for anxiety and stress reduction. It's a practice but a wonderful practice. Music therapy and stress management and yoga also were all things that had strong evidence for application. And then grade C, things that could be considered are acupuncture, massage, and relaxation. And I think in the ones that can be considered, especially when you're dealing with a symptom where you have a direct, immediate sense of the change, trying it out to see if in fact it gives you some relief really is a great thing, because what's most important is for the person themselves. So that's one thing for quality of life and symptom management. You can do some experimentation when there's no harm, especially associated with it. Depression and mood, meditation came up, A again, and so did relaxation. And relaxation, there's a sort of a process of supporting people to get relaxed. That's sort of more standardized, not just telling someone to relax. Massage, music therapy, and yoga were all recommended for this. And acupuncture, healing touch, and stress management all could be considered. Fatigue, ones that came out, nothing that were in the A and the B category. But American ginseng, acupuncture, yoga, and hypnosis were ones that can be considered. And exercise, which Dr. Arora mentioned, and I'll talk about again, would definitely be an A consideration in this, if not a B, or B if not an A. But it's not one that we reviewed in this. So just because you don't see it, that's why it's not there. Acetyl L-carnitine showed no effect, and guarana showed no effect, so it was not recommended. Quality of life, there was meditation again that showed an improvement in overall quality of life. So this is using validated questionnaires to get a sense of, you know, does the person who's going through this particular recommendation, is there an improvement for that group in the treatment group? And so it's a validated control, a validated measure against which there's a control to look at. And meditation came up as high, yoga high as well. And then grade C can be considered were things including acupuncture, qigong, reflexology, and stress management. Mistletoe was interesting. There was actually quite a few studies. There was 4 clinical trials that showed significant improvements in quality of life, but because there was some concern about it being a biologically based therapy, the absolute certainty around safety couldn't be applied, and therefore it didn't get to the ranking of a B, which it probably would have based on the evidence in this case. Chemotherapy induced nausea and vomiting. Grade B, so we see acupressure and electroacupuncture actually being supportive for nausea and vomiting, and ginger and relaxation as considerations. Certainly for some people, ginger works remarkably well when you see it in experience, but not for all people. But that's something that could be considered. Glutamine did not show up any effect in this case. Sleep, the only one that came up with any recommendation that could be noted in this was yoga as a support possibly in sleep disruption. And then for pain, massage and healing touch could be considered. So too could music therapy, hypnosis, and acupuncture. And then for neuropathy, this is really the one thing that came forward that was a recommendation against doing a particular therapy based on the evidence that's there. And this was acetyl L-carnitine, which is not recommended because it seemed to enhance the neuropathy in this case, whereas previously it had been believed to be supportive. Lymphedema, the only 2 things that came forward, and not very strongly so, but still did come forward with some evidence for benefit, were laser therapy and manual lymphatic drainage, and compression bandaging as well seem to be equivalent. For hot flashes, only electroacupuncture and acupuncture showed up in this case as a grade C, and soy in this case did not seem to have an effect. So this is not recommended against, but it was not supported by the evidence from this review. And then for acute radiation related dermatitis or an inflammatory reaction based on the exposure to the ionizing radiation, aloe vera did not show any benefit, nor did hyaluronic acid cream. So, you know, these are the findings. It's it's limited by the evidence, but those guidelines are quite, I think, are important to know about because they are the sort of the most formalized evidence related to this at this point anyways. That said, there is still a lot of evidence that's out there that didn't necessarily get reviewed in this that I think are important, and we're getting more evidence as we go. Some summaries from a website that the Oncology Association of Naturopathic Physicians has developed, which is called the Knowledge and Integrative Oncology website, is a repository of syntheses of original papers that have been peer-reviewed and summarized. And they provide more sort of clarity on some of the original research and can be dug into that way. So I'm just going to present a few findings from this. But in this case, looking at chemotherapy-induced peripheral neuropathy, there was a systematic review where 13 eligible RCTs were included. And from this review, the authors report that vitamin E, glutamine, a particular form of TCM herbal, Goshan Jinkian, and omega-3 fatty acids actually may be supportive in reducing chemotherapy-induced peripheral neuropathy. And however, the acetyl L-carnitine, just to reinforce that, as actually could worsen the situation. So not a recommendation for that. In another review looking overall at women with breast cancer who use Chinese herbal medicines alongside chemotherapy, there did seem to be a better improvement in tumor response and quality of life compared to women who use chemotherapy alone. And this actually comprised 33 different randomized controlled trials. And this was not limited to English language publications or anything like that too. So there seems to be a signal in this that there is a benefit. So that's just something to note. In terms of one looking specifically at clinical trials for oxaloplatin-induced neuropathy, again, astragalus, which is a particular herb used in the Chinese medicinal pharmacopoeia, seems to have an effect in terms of improving neuropathy as well. And then another one here looking at omega-3 fatty acids, which are the anti-inflammatory fatty acids that we find in fish oils and in fatty fish from the ocean, especially. There was quite a few interesting findings from this. There's 10 studies, all were prospective randomized controlled trials in adult patients, and 4 of these 10 were double-blinded. And 2 of those were also placebo-controlled. So it's good evidence. It's not like, what the evidence that we have for many of the therapies in oncology, which require, larger numbers and more frequency, but we're getting some evidence for sure. In this case, neuropathy, there's a reduced incidence of peripheral neuropathy with this group. Body weight seems to help support weight maintenance or gain in the case where there was a loss in this, like where that was an issue, that cachexia was an issue. And then body composition may preserve fat-free mass, which is a good thing. We want to be preserving more lean muscle mass and fat-free mass, which is something that Dr. Arora touched on as well. Good to have less fatty tissue, essentially, which are producing an inflammatory cytokines. Fish oil may also have an immunomodulatory action, which can reduce inflammation, even during radiation and chemotherapy-induced immune suppression. There seems to be some support there. Reduced degrees of reactive oxygen species and improved quality of life. So this is a decent review that reinforces the potential that omega-3s may be useful, in fact, as part of treatment. B12 for aromatase-induced musculoskeletal pain, which is something that certainly can happen with some frequency for women who are using aromatase inhibitors, that they get arthralgias, they get joint pains, they get muscular pains. B12, this is albeit a very small study, showed some potential benefit in reducing that as well. So that's just a snapshot of a few studies. This is like by far anything from a comprehensive review, but I think it gives a sense of the scope of different types of therapies that are available for symptom management when it comes to cancer control. And again, we'll talk a bit more about this in terms of concerns for interactions and all of that, but I think being very intentional in your use and your inquiry into these is important. So just some general nutritional guidelines, and this was touched on earlier as well, but having vegetables, having fruit in the diet, looking at essentially a Mediterranean style diet where you're getting high quality fat, you're getting a degree of protein, but not necessarily an abundance of it. And I think there's an overemphasis on how much protein is required. But and there are a lot of good resources. Eat to Beat is a good website that you can look at as well. But having a variety of spices and different things in your diet that don't create a problem for you personally. So diet is a very individualized thing, and I would say not to be caught up in the extremes of diet. And that's one of the things that is important. And don't let diet become a source of anxiety as you integrate this into your approach. That said, there's definitely, choices that can be better than others. And you get a challenge, like here's Eat for the Cure. And they're providing these look at, we got M&Ms, 2 pizzas, and 4 Coke cans there. And this is with Breast Cancer Awareness Month. It's a little bit of a disconnect, I think. And I think we can all recognize that this particular diet that's being emphasized right here may not necessarily be so supportive when you're looking at having a healthy lifestyle and in the context of cancer as well. There's a lot more that can be said about nutrition for sure. But just some key messages, looking at the fatness level in the body, and this was touched on earlier, trying to be lean as possible, but within a normal BMI, a normal body range. So looking at keeping your BMI, which is a measure of your overall weight to your height, being below 25 or 26, but not necessarily getting below 20 either. So, it's moderation, but it's having fitness there. And fitness can be supported by physical activity. Energy density is an important aspect to look at, avoiding fast foods, highly processed sugary foods, which contribute more to weight gain and produce inflammation in their own right. Looking at plant foods as an excellent source of proteins and just generally integrating that into one's diet. Red meat, limiting that to a certain maybe 1 or 2 servings per week would be good, and avoiding processed meats. Alcohol was also touched on, and I think we know that there is a risk correlation with increased levels of alcohol and cancer risk. But basically, if you don't need to be a teetotaler. You can have some alcohol, but trying to keep it to 1 drink or so or less a day for women, and 2 or less for men are the recommendations. You get much more increased risk as you get higher levels. Salt preserved foods, limiting sodium, but 2.4 grams per day is actually quite a bit of salt. And then supplements, the key message, they're not recommended for cancer prevention. This is sort of something from the World Cancer Foundation, and it's not really like cancer prevention. We don't have good evidence with relation to supplements. There are certain ones that I think can be supportive for immune function and can potentially provide a role, but by and large, it's not your go-to. So anti-cancer food guides, things like berries and pomegranates, grapes, flax seeds, these are all things that I would say have an abundance of. Soy, including miso, tempeh, tofu, and edamame, and soy nuts. There is some evidence that suggests that soy can be protective. And we did an extensive review a number of years ago, looking at all the case control studies, all the prospective cohort studies, and there's very little clinical trial data on it, so that is absolutely the case. But the vast majority of observational studies seem to support a possible protective role of soy, and if anything, it doesn't seem to be negative. So I do advise my patients that actually soy is probably an okay thing to take, even in the context of an estrogen receptor positive cancer. I know there's been some controversy around that, and people are still concerned. So if it creates anxiety, don't bother. But I think that if it's been something that's part of your diet, I don't think there's any reason to take it out. That's I can point to the studies on that later. Garlic, cruciferous vegetables, these are good things to incorporate. They seem to have an effect slightly on estrogen metabolism. I'm also a big proponent for mushrooms, even white button mushrooms, which actually have a slight aromatase inhibitor activity, which is interesting. And then lots of dark leafy green vegetables, and green tea also seems to have some potential effect. These are subtle effects, but maybe collectively they may provide a better environment in the body to reduce the risk of progression and or recurrence. So a word more on plant estrogens. Flax. There seems to be some association actually with flax and having anti-proliferative effects in breast cancer. And particularly actually where there's HER2 positive status, there seems to be some support in that, and maybe even protective against primary breast cancer getting it in the first place. So I do actually recommend flax very frequently, and I think it's a useful fiber. It helps to bind up with estrogen that's in the GI tract and stop the recirculation of estrogen as well. And the lignans in flax may actually have a positive phytoestrogenic effect, if you will, almost like a SERM, but maybe that's a little bit of a stretch. We've talked about soy as well already, but there doesn't seem to be a real negative effect. And there are some research summaries on some of these specific ones on our website if you're interested in looking at that further. So I don't recommend though people to take soy supplements and isoflavones. I think that it's probably better to take it as a protein source and in the food. So that's just one caveat. I don't think we know enough on the supplements at this point. And then black cohosh, research is not conclusive, but the sense that these agents are less likely to lead to proliferation and increased risk. That's the overall sense from the studies. However, you know, we don't have an absolute certainty around that, but there's preclinical evidence on black cohosh actually doesn't seem to show that estrogenic activity necessarily. And there were some trials that didn't show any increased risk. These were albeit small trials, so take it with a grain of salt. Or a grain of flax. So supportive though for symptom management, if it is supportive for symptom management and you're considering stopping tamoxifen as a result of hot flashes being so intense, and you found black cohosh or you know, there's other possible options that you can use that they really help, then it may be, I would suggest it's much better to stay with the two than to stop the tamoxifen. So that's just something to consider. And we can definitely support some of these symptoms. I've seen it. I've seen radical changes in hot flashes and other things using certain therapies that can be helpful. Acupuncture can be one of them, but certain herbal remedies that are not estrogenic as well. So last bit, really looking at exercise, I think it's one of the most potent things that you can do. Absolutely. And Dr. Arora talked about this earlier, so I won't spend too much time on it, but it improves all kinds of measures: mood, energy, quality of life, your bone density and architecture. It improves sleep. It does improve the risk of recurrence, and it can improve appetite, and it improves lean muscle mass as well. So yes, 150 minutes of moderate to vigorous intensity activity per week are the recommendations. And if you can include some resistance exercises in with that, weight-bearing exercises, something that's causing your muscles to build is a good addition. So just want to note about some combinations of natural health products with chemotherapy, and I'm going to go through this quickly. You've got a green tea field here on the left and a chemotherapy bag here on the right. What does that create? I think there are concerns. It's important to be aware of that there can be some interactions with this, so not to just enter into this. I think by and large, the risks have been overblown in some cases, but there are risks, and you don't want to interfere with the negative, the positive activity of whatever drug that you're using to prevent recurrence or to treat your actual cancer. So it's just something to look at. And there's lots of things that modify this issue of interactions, and especially when there's polypharmacy. So we get knowledge from studies, a variety of studies that look at ideally some drug probe studies, and there's other things that you can look at it, modifying the cytochrome enzymes, things that metabolize the drug, but also looking at ways in which the drug and the natural therapy may interact from a pharmacodynamic standpoint, where there's a direct impact on the ability for the drug to act. So that's one thing. There is the potential to change the metabolism of the drug, and there's the potential to block the mechanism of action. However, there's also the potential for synergy and enhanced efficacy, which we have some data on from certain studies. And when there's enough evidence for the application together, then by all means we should use. But if there's no evidence at all, then taking a precautionary principle and avoiding that potential risk is the way to go. And if there's obviously any interaction evidence for harm, we avoid. This whole issue of the antioxidant debate is one that continues to unfold. So I won't speak much more to that, but there's a whole literature and a whole a debate around there. But basically, you do not want to interfere with the oxidative destructive potential of chemotherapy and its useful function in that context. But at the same time, there can be the potential to support actually a healthy response in that. So there's a balance around there. And again, it's looking at the specific evidence when we have that. You can look at issues with respect to the clearance of the drug in terms of understanding when it might be safe to combine, or not necessarily combine, but to restart the natural therapy. And that's something that we do. So we look at the half-lives, for example, of the chemotherapy, and we'll look at the function of it and where it's taking some action. And then we'll also look at the metabolism of the natural therapy as well, to consider when it would be safe to administer in the context. So I think there can be a more sort of nuanced approach to this, but by and large, it's good to avoid high dose antioxidants within a few days prior to and especially following the chemotherapy. It's really important to respect the considerations of the pharmacist as well as the oncologist and the primary care physician in terms of all this. And it's much more important to exert more caution where curative treatments are certainly possible with conventional care. So just some final thoughts and recommendations is good to be informed, I think, about the field, and to know that there is a lot in there, to be really intentional of what you're trying to achieve with the complementary and integrative medicine, to be communicating this with your healthcare practitioners, and to involve people with some expertise in this. Absolutely see it in clinic all the time that integrative medicine can be very helpful, and it's really geared at the particular individual and what they're dealing with and what they're suffering through. And then obviously the interaction of the awareness of interactions and benefits is important in that as well. So that's it. That takes me to the end. And just a note, we have shifted from the OICC to the Center for Health Innovation if there's any confusion around that. So thank you so much.
Perfect. Thanks so much, Dr. Seely. That was an incredibly comprehensive overview. And I think we have tons of questions, so we'll dive right in. We do have time for a few. First, in terms of vitamin D, so a couple questions around that. Is there any evidence that supports mega doses of vitamin D? And then also, is this something that could be recommended in terms of helping reduce the risk of recurrence for breast cancer patients?
Yeah, great question. Vitamin D is being explored a lot in the context of cancer and breast cancer, and there is evidence that a sufficiency level of vitamin D is important. So looking at serum status of vitamin D, and there's sort of a bimodal effect. So if you get too low, there's more of there seems to be a higher rates of disease incidence and progression potential as well. Whereas if you get extremely high, then there's the potential for toxicity. So megadosing I'd be very careful with, and be good to do in the context with a clinician that knows what they're dealing with there. But you know, anywhere between 1 and 4,000 is probably not megadosing, for one thing. So I try to get people into a sufficiency status, which is between 100 and 150 nanomolar. And what's considered deficient in Canadian reference range is less than 75, and toxic is over 250. It takes some time. It's a fat soluble vitamin to build up levels. So it can take some time and the right dosing, and really people are different in this, but it's frequent that people have an insufficiency level in vitamin D in Canada, especially.
Fair, especially going into the winter here. So in terms of B12, do you have a suggested dose for managing musculoskeletal pain?
Yeah, you know, I put the B12 there with some concern, because there's also some associated possible risk with triggering what are called oncogenes, and that the expression of these may be a negative effect. But if there are arthralgias, I would consider the use of 1,000 micrograms as a possible B12 dose to see if that can help. And it's a water soluble vitamin, so it does show its response relatively quickly. Some people actually don't absorb it very well, so there's cases in some situations where actually an intramuscular injection is the right method to receive it.
Okay, great. Thanks for that additional information on that. We have a question around turkey tail mushroom, which someone was taking for about 6 months to help with her breast cancer, and then was told by a pharmacist that it may interfere with her tamoxifen. Your thoughts on turkey tail mushroom while receiving breast cancer treatments?
I really like turkey tail. I think that it's used a lot. There's been a number of studies of turkey tail, or also known as Coriolis, especially in Asia. And it does seem to have an effect on innate immune system to support that. And I do typically use it. And even like CYP2D6 is the particular enzyme that's metabolized, that's required for the metabolism of tamoxifen, although CYP3A4 is another one that does do some metabolism there too. But anyways, my sense is that I will use it in that case. Yeah, I do. I don't think it interferes.
Okay, thanks for clarifying that as well. And then the effects of carcinogens in food. This is sort of a broader question, but for example, pesticides like glyphosate, weed killers, anything that can you comment on that in terms of its relationship to breast cancer?
Yeah, there's, I think that pesticides can potentially have a negative effect. And not necessarily, like, their toxicity may be modulated because they are potent estrogenics. They can be considered xenoestrogens, or estrogens coming from outside the body. And so those xenoestrogens can actually be very potent in terms of triggering breast cancer cells. So in hormonally responsive cancers, including many of the breast cancers and prostate cancer, not all, but I think it's more relevant perhaps in that case. So, you know, it's hard though, because organic food's more expensive, and it's better to eat vegetables, even if they're not, you know, organically sourced, than not having them. So again, not to create anxiety around it, but, you know, it's looking at things like the Clean 15 or the Dirty Dozen to make some food choices, to look at the food choices that may be less impacted by pesticides. That's something that I often recommend. But yeah, I do think there's an environmental contributor when it comes to this.
Thank you for those helpful suggestions as well. And then we do have a couple questions, particularly around antioxidants and whether or not they interfere with chemo and the efficacy of chemo, or even Herceptin. Are they safe to take while doing some of these cancer treatments?
Yeah, it's, you know, I talked about that briefly. There is the whole idea is that antioxidants may in fact interfere with chemotherapy in particular, because some of the chemotherapies function by creating an oxidative reaction. And I'm sure Dr. Rutledge can go into this more, but with radiation, ionizing radiation creates, you know, free radicals that destroy rapidly dividing cells, and may also have an effect, you know, from an immune standpoint too. But so where there's no evidence for application combined, I avoid that combination. So things like high dose vitamin C, right, in the context of radiation or a coenzyme Q10, I say, you know, let's take this out for now and use it at a time where it may be more beneficial. There are certain antioxidants that are considered antioxidants, but that actually, you know, have some evidence for benefit. Melatonin is an antioxidant, and there's a lot of studies that look at it in combination with chemotherapy, and it seems to be supportive. So it's, I don't think we know enough, and also not all the chemotherapies work by provoking an oxidative reaction too. It's yeah.
Well, we really appreciate your time, your insights, a tremendous presentation. So thank you for that. We unfortunately didn't get to all the questions, but I think what we'll have to do is have another session and just do a Q&A. Dr. Rutledge and I were speaking about that before. Just have all of our speakers back just for Q&A. So we'll look at doing that maybe in the new year. Thank you so much, Dr. Seely. And Kathy, I'll turn it back to you.
Yeah. I just want to really thank you on my behalf. That was very informative and very insightful. Thank you so much for sharing that. And I'm sure we'll speak again, and we'll continue this great conversation and great information from your presentation. Thank you.
Thank you so much. Okay.
Thank you. Okay, so yeah, I think we've had a lot of questions, so we're gonna have to find another time for all that. And now we're going to welcome Dr. Rob Rutledge, our next presenter. Dr. Rutledge is a radiation oncologist from Nova Scotia Cancer Center. He is also the chair and CEO of the Health and Cancer Foundation, which focuses on healing body, mind, and spirit. Dr. Rutledge will be sharing insights into how we can transform the emotional energy we experience from a breast cancer diagnosis. Dr. Rutledge, I will now turn the presentation over to you. Thank you.
Thanks, Kathy and Jen. And wow, it's been a great afternoon. I would ask everyone to actually stand up right now and kind of stretch and close your eyes and not look at the screen. We've been sitting for a long time. Yeah, so just do what you need to do in terms of what's good for your body. Maybe you can close your eyes, maybe even rub your tummy a little bit, just a little self-soothing, little oxytocin. Yeah.
Thank you.
Great, thank you. So it's a great honor to work with CBCN and Jen and team. Looks like I'm getting a chance to share a presentation here. So I'm taking it, you can see the screen now. First of all, hats off to everybody who's joining this presentation. I think that sends a huge message to how to heal. And I also strongly endorse what Dougal has been talking about, which is the integrative medicine, which is getting that combination of the best from the conventional system, Roochi's fantastic, science and all the, all the infrastructure that really maximizes your chance of cure from that side of things, and then empowering yourself, body, mind, and spirit. That first level of integration is using that understanding, empowering yourself with the information, whether it's around the medical system or, the complementary world. So it's super important, getting the best care, advocating for yourself, recognizing you're the most important person in the medical system. They're there to serve you. So you advocate for yourself, get the best care. And then, this is, for me, this is now standard. It's pretty obvious that, if you can get yourself up to that activity level, I believe there's actually an influence on diet in terms of outcomes. I think there's some good science there. And I think Dougal's recommendations were excellent. I highly endorse that. Obviously, you want to maintain a reasonable weight. We're talking about sleep and sleep hygiene. Anything that increases your risk of breast cancer, you want to avoid, right? Like if smoking is a risk factor, we want to stop smoking. If we know there's certain activity like maintaining a reasonable weight reduces your risk, then you want to do that after a diagnosis. You don't want to turn any slow-growing cancer cells in your body into fast-growing cells if there happen to be some cells there. But then there's the level of the mind, and our mind is obviously connected with our body. And even Dougal was talking about the different scientific proof that meditation, for instance, improves quality of life and helps with lots of different side effects. And we can go deeper in terms of reframing, cognitive therapy. Today, I'm just touching on one little slice of a much bigger pie, which is working on the emotional aspect of this. But there's also the aspect of nurturing a spiritual perspective. And the fact that you did show up and are listening to this presentation really does set a meta message from that level into healing and recovering and so on. So hats off to all of you. I'm really happy to be here. I can tell a little bit of the story because I've been, it's a 30-year plus journey trying to understand what people can do to facilitate healing. And it started in the 1980s when I was in medical school. I read this book called Love, Medicine, and Miracles by Bernie Siegel, who's a cancer surgeon. And he talked about his exceptional cancer patients, the ones who did really well, who recovered from cancer, who outlived their doctor's predictions, et cetera, et cetera. And from reading that book, I knew I wanted to study this whole principle since that time. And I want to share with you within the context of kind of emotional health and really taking care of yourself, some of the principles of the remarkable cancer survivors. So Bernie's attributes of his exceptional, and I take exception to exceptional because I think we all have the capacity to really maximize our health and to heal in lots of different ways. But the first one is actually his remarkable survivors were truly willing to accept their situation. There wasn't this kind of extra struggling against reality. And as a corollary for you on this topic is that we need to understand that we're human. We are going to have difficult emotions. At what time in your life did you not have like good days, good months, bad months? It's this kind of ebb and flow of life. It's natural that we have these emotions. We don't have to fight against the difficult emotions, and acceptance is the first kind of step around that. But Bernie also talked about, his exceptional patients not viewing even recurrence of cancer, or even death, as a failure. You know, it seems paradoxical, but his remarkable survivors put their energy into the things they could control, right? So what is it that's most important to you? How do you want to bring your spirit into this world? And when we focus at that level, we bring love and connection and peace and joy, whatever you want to manifest. When you put your energy there, you can let go of more of the worries and the difficult emotions, and you start to live out of your values and your goals and so on. So that, I think, is the ground for having an effect at the kind of physical level. There's also this idea that there's always an opportunity, right? So yes, it's very difficult in lots of different ways to have a breast cancer diagnosis, but it's also an opportunity. Like, how do we want to refocus our lives? What's our priorities? How do we want to bring the best of ourselves into this world? And so there's always this opportunity each day of connecting and loving and being your best self. And lastly, Bernie talked about his exceptional patients were truly willing to love themselves, right? The warts and all were perfectly imperfect. And they were also willing to do what it takes to take care of themselves, right? So spend some time on that self-care activity. You know, when you exercise, which is, you know, it's been pretty clear from each presentation there, you're sending that meta message to say, I want to recover, I want to get better, to your body, to your spirit. And that's self-care, that's self-love. So that was my first taste, and I kind of continue to watch the literature and try to take it from a kind of scientific perspective and from a holistic perspective, recognizing that I didn't understand everything, that there was much more to this life than just the scientific paradigm. And so the next person that I read about, so Alistair Cunningham runs the Healing Journey program, Princess Margaret Hospital. He has a 7-level series. His 7th level, he's actually still working on right now, around the spirituality part of this. But he wrote a very provocative book about how is it that we can influence our outcome. And one of his studies, he looked at people who had an incurable cancer diagnosis. On average, they all were expected to live about a year, but those who really were self-involved, did the meditations, did the contemplations, you know, really took their healing journey seriously, they lived 3 times longer on average than those who didn't. And he even had the kind of spontaneous remission, you know, patients that had incurable cancer who were alive and well 20 years later. So that was, you know, he did it prospectively in a kind of more scientific fashion. What did Alistair talk about? He talked about acceptance. So again, this willingness to see the truth for what it is as our starting point, start afresh each day, even each moment. He talked about authenticity, which in some sense means to really acknowledge that we have our own direction, we have our own intuition, and we have our own kind of inner guidance, and a willingness to kind of listen to that and let that be the guide. So you might find the naturopath that way. You might find, you know, the activities or the healers that are just right for you. So you listen to that. But it was lastly, they're taking action. And the fact that you guys are listening to this presentation now, I know you're in that mind frame of, yes, I'm going to learn, but I'm also going to be proactive. And it sends, again, the meta message of healing towards yourself. So autonomy in action. 2014, 2015, Kelly Turner, she's actually a PhD and a psychotherapist, but she had this idea of interviewing all the people who have undergone a spontaneous remission. And she didn't like the word spontaneous remission because it just sounds like it happened like by chance. She called it radical remission because the people who had undergone these incredible recoveries all had done the work. They had actually taken their healing very seriously. And so she did these interviews of like 80 plus people. Now she's interviewed like hundreds of people since, but she found out there were 75 factors, and it was essentially 10 of them that were common amongst all of them. Exercise is number 10 that's not on the list here, but her 9 factors are the following. So the first one is really around this kind of proactive attitude, listening to your gut, doing something specific, including diet. Now, interesting around herbs and supplements, there was no one overlap. So there was no one medication herb supplement that actually people took on average. And so I think it's actually just a marker to this kind of proactive attitude. I'm highlighting that these people also did their emotional work, their psychological, spiritual work by releasing the suppressed emotions, by promoting positive emotions. And that's not like I have to be happy all the time. It's just like facilitating the activities and the ways of being such that I can express my joy and content and connection and gratitude in this world. So that was part of what these people did. And then lastly, we are human and connected, having this kind of stronger reason to live and finding a deeper spiritual connection. So again, 2 out of the 9 were physical and 7 out of 9 were the psychospiritual side of it. So that's her work. And I just want to give you a few little key points that she points out in her book, Radical Remission. So around the emotional issue, so the idea is that we can actually work on this. We can take an active role in understanding ourselves, in releasing the suppressed emotions and, choosing, because your thought pattern actually influences the gene expressions, like 200 plus gene expressions, influences the stress levels, influences the hormones in your body, influences all aspects of your health. And so when we do that work, when we figure out ourselves, we can actually start to transform that into healthier wear. I just add this kind of second sub point that, we live in this social media society and we're exposed to television news, and we really can reduce this kind of distressing, sensationalized media that kind of gives us kind of a stress reaction. So we want to kind of be kind to ourselves, take care of ourselves, use social media in positive ways that connect us with other people. So she says, journal and reflect, practice daily forgiveness, right? Release those grievances. They're causing a stress reaction. We need to come into space around that positive space. We're going to talk about stress there, and realizing that we have very short period of time to actually, cover this. It's more like a taster of some of the ways you can promote your own health. See a therapist. I think that's extremely important to process, work on those issues. And then ultimately do the things that bring you joy. Let go of things, give yourself the space to do those things. Friends, rituals, right? Could be an opening ritual, setting your intention, a meditation, last thing at night, and exercise is super important from the emotional side. And lastly, I don't know if you've seen this book, so published earlier this year. We just interviewed him. So Jeff is a psychiatrist, works at the Harvard Medical School's head of behavioral program there. He also has a master's in divinity at the Princeton Seminary College, and just a remarkable character. And life had conspired such that one of the nurses that worked in the oncology clinic contacted him in 2003. She was in Brazil at that time, and she was noticing these amazing, she had pancreatic cancer. She had these amazing experiences and seeing people that are recovering and so on. And she tried to prod him into starting to study people who've undergone spontaneous healing. And he refused, but she kept sending him people. And finally he agreed, and he started interviewing in a very kind of scientific way. He started interviewing these folks. And again, I love this book because he's very pragmatic. He keeps it within the scientific realm, and it's also just chock-a-block full with wisdom in terms of the practical ways that you work on your own healing at the deeper psychological and spiritual levels that his remarkable survivors followed. And so his 4 pillars of health included healing your stress response and healing your identity, which is, really pointing back to the kind of childhood traumas and issues and the ways we look at ourselves, and we can kind of release that, the untrue identity and kind of come to our deeper identity. It really does release the kind of healing potential within the person. So remarkable book. I recommend it. So big picture, if I'm going to just focus on that smaller pie and recognizing that it's really one holographic human experience, what do I say about the emotions? We normalize it, right? You get a cancer diagnosis. There can be some grief around that to kind of shock, the shattering of expectations, your worries about what's going to happen in the future, your worries about your loved ones. it's normal to have those things. We don't have to fight those off. We don't have to put on a happy mask. It's so we come to recognize our humanness and not fight against it. Having those emotions for, a shorter period of time is not going to affect your health. If you stay depressed for a long time, then yes, you could definitely influence your health. But anyways, normal. Emotions carry information. They help to protect us. They connect us with other people. It's an intelligence that we have within our body that we can tap into. Sometimes they go awry and we don't have to kind of buy every line that is sold to us, but it's just information. It's just energy. And that's why I label the talk transforming emotional energy, because it is energy and information. And lastly, you can do the work. You can actually start to practice stress reduction. You can start to work on the difficult emotions, the suppressed emotions, and there's methodology, there's science that helps it. The other one I'd absolutely say is that it's important to stay connected with the most important people in your life. And, at least having that one wise person who can hear you out so you can tell your truth to them, like setting up the conversation saying, I don't want you to correct me or offer me advice. I just want to tell you how I'm feeling. And that is therapeutic just by itself. Our evolutionary history, just to say, the reptilian brain is the kind of fight or flight part of it. The limbic system is the seat of the emotional system. And I call it the stressed, irritable system, even though it's also an approach system. And then we have the wise and compassionate brain, the kind of neo-mammalian brain. And part of this is trying to think about how can you live out of your wise and compassionate self. And I don't know if you can see me in the little picture there, but there's the hand model of the brain, essentially wrist, reptilian brain. The thumb is the limbic system, which is the approach or the stressed irritable brain. And then you've got your wise compassionate brain above that, which is frontal lobe. And you can, when you stay in this level, then you can help settle down the emotional brain. You kind of help set it. When you get really stressed, upset, you flip your lid and you lose it. And so how is it that you can kind of stay within that that framework of your best, loving, compassionate, wise self? That's part of it. So the first teaching is around stress. Stress is what occurs when something important to you is at stake, right? So whether it's a small thing like trapped in a traffic jam, or you're worried about an appointment and a test result, it's stress is that experience when something's important to you. And that's an internal experience. There's 4 levels of teaching around stress, and I'm sorry for the big slide here. First of all, we build resilience, we build strength, we take care of the frontal lobe of our brain by exercising. Exercising actually helps develop that frontal lobe capacity, keeping yourself relatively well rested. I believe the healthy diet also, whether or not spiking in the sugars or the other components of that, the right healthy proteins, et cetera, not allowing your sugars to drop off is important. Meditation, definitely, as you meditate, you develop this part of your brain. It helps the left prefrontal lobe, which has a more positive mood. It accesses your wiser self. It is your best self here, right? So you do those things on the day-to-day so that you'll be more resilient. Life presents you the same, challenges. It's the same external environment, but you're in a more positive state and better able to make good decisions, and then your body is healthier as well. Stress teaching, kind of a level 1 teaching, is recognizing when you're suddenly stressed, upset, flustered, you feel kind of stressed out, angry, upset, overwhelmed. And the earlier you can recognize that you kind of got yourself into that fluster, the easier it is to kind of settle yourself down. And what I tell people is almost all the time, you have time to actually settle yourself down. You can actually do this with me now. Press the pause button on the stressful situation. Become very curious of the physicality of your body. What does that feel like? Be mindful of that. 4 slow, smooth breaths, especially on the out breath. Remembering to bring your mindfulness to that experience. and then you can talk to yourself. You've kind of put yourself into the relaxation side of the nervous system, the wise and compassionate self. You're starting to come back on board with your wise and compassionate brain, and it settles your nervous system down to a certain extent. Now, not perfectly, but to a certain extent. The second level teaching is that you need to practice a relaxation technique. And that's, it's a meditation body scan. It's something that's the technique of bringing your attention back and actually promoting the relaxation side of your nervous system. I've added a heart rate variability monitor to that. I visualize hugging my wife as I'm doing that meditation, and then I can see that my heart rate variability increases, which is good. And that actually is better at, teaching myself the relaxation response. So what I say is reset your stressometer at that level. Reframing stress is enhancing. Essentially, if you can teach yourself a change in mindset that you want the kind of energy of the situation in order to learn and grow and become stronger, just by believing that actually changes the neurophysiology of your brain itself. And that's part of a longer talk. And lastly, really kind of going to the source. What's the source of why am I feeling so stressed in this situation? And the core beliefs about whether I can handle things or how other people should act or how the world should act or how life should be. If you can work on the kind of cognitive side of it, that often influences the emotional side of it and then empowers your body further. So stress teaching by itself is, whole talk. So that's just a quick little summary of that one. So around that third level of stress, so what's your relationship to stress? Do you see stress as toxic? You really want to minimize and avoid it. You talk to yourself like, oh, my life is toxic. This is too much. I'm not doing the right thing. So it's like this kind of negative self-talk around an outward scenario. Or can you say to yourself, well, stress is a part of life. I can actually utilize this. I can embrace stress. So my anxiety means that something is important at stake. So here's a good opportunity to learn and choose the energy of the situation, right? So that flip can actually allow you to function better, learn and grow from the same scenario, same stressful scenarios. Yes, there's still going to be stressful situations out there. That's not going to stop, but you'll be in a different space. So how do we release the difficult stuff? First of all, what's causing the emotion, right? So I'm suddenly feeling angered, or I'm suddenly feeling flustered or scared or numbed or overwhelmed. So you're trying to figure out like what is actually happening here. It's kind of the meta consciousness of watching yourself, not having to kind of get caught up, but simply watching, oh, geez, I'm feeling irritable right now. So you go to the source of it. Do you need to take action, right? Because there can be something that's quite clear as to, there's a situation, someone's yelling at you and it's inappropriate for them to yell at you. You might have to say, stop that, or you might have to leave, or, those type of things. So it's like an information. It's okay to be upset. If you're anxious around a breast cancer diagnosis, you're learning now what you can do to maximize your chance of recovery and to maximize your chance of cure and to heal your life, right? So you're using the anxiety of the emotion to actually empower yourself. So we don't want to shut all those down. Can you honor your emotions, right? So sometimes it's like grieving, darn, I got a breast cancer diagnosis and now I can't go to work and my kids are upset and, I'm feeling really badly about this. And it's healthy to grieve, right? So some sense allowing those difficult emotions to go through you, not to repress them, to have a good cry when you need to have a good cry. And so you honor those emotions in a way that's healthy. And if you can allow them to release, then you will have good moments. And then, a week later, you'll feel anxious at different times. So it's going to keep coming up and going, but you don't have to stop them from happening. You can actually honor it and recognize that you're human, that this is normal for people, women, to go through these type of experiences. So you express your grief, frustration in a healthy way. Sometimes there's a distortion though, right? Like people shouldn't act this way. And, when you see that kind of distress that's happening, you can kind of go to the source of it and recognize, well, that person's just doing the best that they can, right? And so ultimately, you're trying to figure out whether or not you're, it's appropriate to let go of that thought or situation. Okay, so just a couple more slides then. Unnecessary stress or emotion is this idea that you shouldn't be feeling in a particular way. It's like, I'm angry and upset. Well, I got a breast cancer diagnosis. I shouldn't be angry and upset. I should be positive. People tell me I should be positive. I'm not doing this right. And then you're getting frustrated with yourself. And so that's kind of the second arrow. And really, you want to be kind of kind in that situation. And there are different ways to do just that, is to show a kind of kindness to oneself. Self-compassion. I don't think we're going to have time to go through this by itself, but I'll just take you through the idea of self-compassion based on this book. And that is to be able to be mindful of what's happening. I'm just going to flash the slides here. And there's lots of different data to say that you can actually improve your outcome, improve how you feel by taking care of yourself in self-compassionate ways. So 3 elements: to be able to recognize that it's there, I'm feeling tough, being moved, and then realizing that this is a common humanity. Self-compassion rituals to put your hands over your heart. And I'm just going to finish off with this technique. So think of a situation in your life that's difficult, that's causing you stress. Right? So you're allowing yourself to feel a difficult, stressful situation in your mind right now, and you're having some feelings. The first thing to say is, this is a moment of suffering. This is tough, and you can say it in different ways. Suffering's not the right word for you. You could say this hurts, or ouch, or this is stressful, and recognize the quality of my voice now. It's a kind of more compassionate voice. The second step is to recognize that this is what happens to human beings. If you're a woman getting breast cancer diagnosis, this is how you would feel in this situation, right? Or other people feel this way, or I'm not alone, or we all struggle in our lives. And then lastly, it's kind of this encouraging part of yourself that says, I can take care of myself. Let's take this a step at a time. So like hand over your heart, kind of the oxytocin level. May I be kind to myself, right? So even right now, say that or feel that to yourself. May I be kind to myself? And there are lots of different ways to say that, right? May I give myself the compassion that I need? May I accept myself as I am? May I learn to accept myself as I am? May I forgive myself? May I be strong? May I be patient? So you're looking for what is needed in the situation. So the 3 steps: notice, right? I'm feeling this way. Say something, oh, this is painful, this hurts, soothing touch, and then some sense of self-affirmation. The difficulty is still there, but you're being kind to yourself as you're going through that. Just a quick pitch. I'm in the middle of a 8-part series right now. In fact, the next one, which is next Wednesday, is all on emotions. Like, we're just talking about how to work with emotions. It won't be the very quick presentation. It'll be much, much more in depth. We did a whole series on diet and other empowerment pieces, coming up, spirituality, and an overview of the remarkable cancer survivors. So you can find that on healingandcancer.org, upcoming events. And I just want to plug that we also have a Spirituality and Cancer weekend Zoominar, the weekend of the December 4th to 6th. You can find that at healingandcancer.org as well. Thanks again, everybody, for your attention and staying there. And it's just, what a great pleasure to work with the CBCN. Thanks, Jen and Kathy.
Thanks so much, Dr.
Thank
Rutledge.
you. Thank you.
Zoominar, I love that. That's great. We're going to have to use that, a Zoominar. So we are a little bit over, but I'd like to there's a couple questions that have come in. Please feel free to submit your questions. We want to make sure that we do have still a little bit of extra time with Dr. Rutledge. So we'll dive right in. Dr. Rutledge, in terms of, someone mentioned releasing suppressed emotions, right? And you were speaking to that. And there's some questions around that in terms of, how do you know? It's a little abstract, right? How do you know that you've done that? How do you know that you're accomplishing that?
Yeah, do you know what? I think to me, it's around functionality, right? So how are you generally feeling on the day-to-day? Is your mood relatively positive? Are you doing the things that you love to do? Are you brooding? Are you kind of ruminating? Keep on thinking, going over and over a situation? Or do you feel like you're bottling up, like you're kind of going to explode? So we neither want to brood nor bottle. And then obviously talking to a therapist or a counselor, your family doctor around those issues. I mean, heck, we're human. We're not going to release all the suppressed emotion. It's more like we're allowing some of it come up, allow the healing come in. And oftentimes this happens over months to years. And then that's when the kind of remarkable insight can happen. And it really kind of transforms your kind of reality of your life experience. So I just say go for what works. I think that's the takeaway on this one.
So it's keeping at it as well.
Yeah.
That's some great insights. Lots of recommendations in terms of some of the programs you've done. So we're seeing a lot of those come in actually in comments.
Thanks, guys.
People who found it incredibly beneficial. And someone going back to how you'd earlier said that you don't want to make lifestyle changes that turn slow growing cancers into fast growing cancers, and maybe doing a recap of what some of those things that we might be doing are that are sort of impacting us negatively.
Yeah, so that is such a fantastic question because it really summarizes what the 3 sessions have been pointing people towards. So just to give you the kind of context, classically thinking, we think about normal cells that get enough damage, get enough changes, they ultimately turn into cancer cells. But the ongoing damage to those cells turns the slow-growing cells into fast-growing cells. And we want to kind of reverse that process. So we know that, for instance, smoking causes damage, or a fatty diet causes damage, or lack of exercises can add to increased inflammation, which is probably one of the causes of how cancers get developed. We want to reverse those causes such that if you do have some slow-growing cancer cells left over, they kind of stay dormant. They don't get more hits. They don't get more changes. They don't mutate into more aggressive cells. And I think that's part of why you can actually increase your chance of survival and cure by doing those extra things. And the extra things are obviously following the medical system and making sure you can comply with all the treatments, because that's super important by itself. But exercise, right, in a way that's fun and sustainable, often social, 150 minutes per week on average. Just do it in a way that's fun for you. Dietary stuff, what Dougal outlined there with the kind of anti-inflammatory diet, mostly plant-based foods, lots of variety, super important. Anti-inflammatory, feed your bacteria in your gut. Number 3, maintain a reasonable weight, because that also changes the chemistry within the body. Number 4 is the sleep side of this, right? Staying in the dark at night. Number 5, practicing a relaxation technique. And then we're into the deeper stuff of the kind of stress reduction and working with the emotional life. And I think if you do that, guys, you're really maximizing your health and happiness. And it really summarizes the incredible wisdom from the 2 other presentations as well.
I think that's a wonderful note to end on. Dr. Rutledge, thank you so much for your expertise, your insight, sort of wrapping up the day nicely for us, and for being here with us today. We really appreciate it. Kathy, I'll turn it over.
I just want to thank you. That was great insights, great wisdom, and your energy is always fun to hear. Thank you so much.
You're
We're
welcome.
going to need a lot more time on these topics, that's for sure. And I thought it was brilliant the way all 3 presentations just flowed nicely and just worked out beautifully into the whole session. The package was brilliant. Thank you. Thank you.
I'm happy to stay in the line and answer a few questions now if people want to do that. But Jen, I really think that we could have 2 hours of questions and it would be extremely helpful to people. So
we'll definitely have to come back to is doing a full Q&A session with each presenter, and really allowing for the time to have that.
Yes, thank you so much. Jen, I'm going to turn it over to you, and you'll sign us off, or what are we going to do?
Yeah, well, just thanks again for all of our presenters for joining us today, and obviously for sharing all of your insights with us, which was tremendous. And Kathy, are you still able to see my screen? I just want to acknowledge again all of our sponsors
Right.
who supported this program today. So Novartis, Pfizer Oncology, AstraZeneca, Knight Therapeutics, Lilly, Merck, and Roche, who made this possible. And there's more information. And if to subscribe to future sessions, you can visit us at cbcn.ca.